Hello everybody and welcome back to my channel. In today's video we're going to be talking about barbiturate. So why barbiturate? Because these were the drug most often used in anesthesia for induction to put the patient asleep until propofol came in, but they are still used in other countries, and it's still important to know about them because then for the other videos we can see the similarity and the differences between these and the actual drug that we use for induction. So barbiturate derived from barbituric acid. So by essence, these drugs are acidic drug, and we're gonna know why it's important to know that. So they derive from barbituric acid. Barbituric acid is the addition of urea and malonic acid. These two makes the barbituric acid. So what is their mechanism of action? So barbiturate are gonna be GABA agonist like activity because they're gonna bind on the GABA neurotransmitter in the brain, and we know that GABA is mostly the main depressant neurotransmitter. So unlike glutamate that is very excitatory, GABA is the one that kind of slow things in the central nervous system. So barbiturate is they're gonna bind to GABA and increase the conductance of chloride ion. Now chloride ion is an anion, is negatively charged. When it gets into the cell, it makes the cell even more negative inside. We call that hyperpolarizing the cell, making it difficult for any action potential to raise. So this is how it kind of gives you those sedative and hypnotic effect. And also it's also going to depress, the barbiturates are going to depress your sympathetic nervous system activation, and they're going to promote the vasodilation effect. So just be cautious with the fluid status of your patient when you give barbiturate. Barbiturate also are going to depress your reticular endothelium. The reticular activating system is located in the midbrain, and that reticular activating system is responsible of keeping us awake. So by depressing that system, it brings those sedative property and hypnotic again. And it's also, barbiturate are also gonna decrease your postsynaptic receptor sensitivity to acetylcholine. Acetylcholine is the neurotransmitter in the brain responsible of muscle contraction. So when acetylcholine binds to the postsynaptic nicotinic receptor, that's when the calcium is able to enter the cell and promote the muscle contraction. So if we have that decrease in sensitivity of acetylcholine to those receptors, we are not going to have much of the muscle contraction, and this is how they promote that sense of hypnotic and relaxation effect. So how do we classify barbiturate? We classify them in long acting, medium, short, and ultra short acting. So the long acting, we can name phenobarbital. Phenobarbital is a long acting used for seizure control. But for this video, we're going to focus on the ultra short acting, which is categorized further in two different classes: the thiobarbiturate, which we're going to talk about it, thiopental mainly, and the oxybarbiturate, which we're still going to talk about in methoxytol. So we're mostly going to focus on thiopental and methoxytol here because they are the one that are ultra short acting to put your patient asleep very quickly, and they also kind of leave the system quickly compared to the others. Now this classification is kind of confusing because by hearing ultra short acting, you think they're just gonna act shortly and leave. No, they don't leave like that fast. They're gonna linger around, and we're gonna talk about it when we get to the metabolism. Now let's talk about the pharmacokinetics. So we're mainly going to focus on this short-acting thiopental and methotrexate. So we're going to talk about the effect site equilibration first. So the effect site equilibration can be defined as the time it takes to your drug to leave the blood and gets to the place where they need to have their therapeutic effect. For our purpose here is going to be the brain, because we want to put the patient asleep. We want that brain to sleep. So the time is take from the moment the medication get into the blood to get into the brain. Now, these ultra short acting are very good in the effect site equilibration. Within 30 seconds, they get into your brain. They are very fast. They have a very fast onset of action. Now, we also need to take note that only 10% of what you administer is going to get in the brain. And why so? Because these ultra short acting thiopental and methotrexate are very liposoluble. So to be able to circulate in the blood, they need to be bound to some proteins that help their transport, help them move around. And because they are bound to the protein, they don't have that access very simple in your central nervous system. So only 10% of what you give is going to go into your central nervous system. Where the rest going to go? The second next tissue that they love, they have a high affinity for your skeletal muscle cell. So because only 10% get in the brain, the rest, the majority is going to get into your skeletal muscle cell next. So this is when you're going to see a decrease in your plasma concentration if you try to titrate your drug, because most of it is going to go in the skeletal muscle within 15 minutes, which is also a fairly nice time. And after the skeletal muscle, liposoluble, the low fat, they're gonna go into your fat and they will stick around forever. Yes, and this is one of their drawbacks, because they're gonna stay into those fat tissues, saturate the fat tissue, and when they fully saturated the fat tissue, they're gonna slowly go back down into the blood, prolonging those sedation effect. So this is a drawback, because when it's time to wake up your patient, you don't want the drug to be still lingering around with extra sedation and then the patient never gets up. So, and this is the main reason why we try to administer the drug based on your body, on lean body weight. So we try to, because somebody can be 70 kg, but out of those 70 kg only have maybe 25% fat. So we really want to base the drug on your body lean mass index. So this is also something to keep in mind. So next thing about the pharmacokinetic is going to be the context sensitive half time. So the context sensitive half time can be defined as, let's say you're giving an IV drip of barbiturate. So if you give the IV drip for a specific duration, let's say you give it for 8 hours, after you stop, how long it's going to take for 50% of the dose that you administer to be out of the system. So this is the context sensitive half time, and anesthesiologists love the medication that have less context sensitivity half time, like remifentanil, because it takes less time for the blood to clear that medicine right after you stop the infusion, right? So the patient can be awake as soon as possible. But with this ultra short acting thiopental and methotrexate, they have a long context sensitivity half time, because they stay in the fat, so the medicine don't get excreted that fast. So the second thing we're going to talk about in the pharmacokinetic is their protein binding. Now, barbiturate have different medicine into their class, and some of them act differently. So we can't say all the barbiturate are high protein binding and or all the barbiturate are low protein binding. So we're going to just focus on the ultra short acting thiopental and methotrexate. So they are very liposoluble, and the more a drug is liposoluble, the more it's highly protein bound. Now, keep in mind that it's the unbound portion of the drug that is active. So the higher a drug is high protein bound, the higher it's susceptible to decrease its therapeutic index. So let's take an example. Let's say we have thiopental and we give another medicine like coumadin that is high protein bound to a patient, right? If the coumadin displays the thiopental to get the binding site on the protein, then we get more thiopental unbound in the blood, increasing its toxicity, decreasing its therapeutic margin. So we want to be careful when our drug are high protein bound, and it also comes with a lot of interaction with other drugs, which is also one of their drawbacks. Now let's talk about the volume of distribution. This ultra short acting, they have a higher volume of distribution because they are able to get into this tissue that are not even much vascularized like fat, right? But their volume of distribution is also limited to specific tissue like brain because they are also highly protein bound. Now the ionization defines their potency, how potent they're gonna be at doing what they are expected to do. So because they are acidic, the closer they get with the pH of the blood, the more they're gonna be in the non-ionized. So if your patient is having acidosis and you give them, because they are acidic, they're gonna be more potent. Acid works better in acidic environment. And if your patient is going through alkalosis and you give this acidic medicine, they are not going to work great. You have to increase your dose because they are not in acidic environment. So now let's talk about their metabolism. So their metabolism, I'm going to talk about them separately, metoxetol versus thiopental. Let's start with thiopental. Thiopental is heavily metabolized by the hepatocyte in the liver and also in the kidney, right? And it has a low extraction rate. Low extraction rate is, I made a video about hepatic clearance on my first semester. If you haven't watched it, please do so. It's a very good concept to understand. But thiopental, like I was saying, has a low extraction rate, by definition less than 30%. And if your extraction rate is low, that means that medicine rely on the enzyme in the liver to get metabolized. Now, keep in mind that the liver has a great stock to metabolize this barbiturate, and it's going to take extreme liver failure to see them not being metabolized appropriately. So because its extraction rate is low, we're going to call it capacity dependent, and it relies on the liver enzyme. Unlike metoxetol relies solely on the hepatocyte to be metabolized. It is extensively metabolized, more than thiopental in the liver, and is flow dependent. It has a great extraction rate, so it's just, if you have a good flow, if your patient is not going through hypotension or shock, metoxetol will be greatly metabolized. So it's flow dependent, it's metabolism. Now let's talk about the excretion. Because these ultra short barbiturates are extensively metabolized in the liver, you are not going to find them much in the urine, like less than 1%. Unlike phenobarbital, which is a long-acting barbiturate, you're going to find it more so in the kidneys because it's also less liposoluble than metoxetol and thiopental. Now let's talk about their half time. So the half time is the time it takes for 50% of the medicine to be eliminated after a single dose. So if you just give a one-time IV push, how long it's going to take for 50% of that drug to be eliminated. So comparing methotrexate to thiopentol, methotrexate will have a shorter half time because it's less liposoluble than thiosulfate, than thiopentol, so it's not gonna linger around in the fat that much. And now that we review the pharmacokinetic, now let's talk about their uses. So in anesthesia, we use this ultra short acting for induction, like when we want to knock the patient out to intubate, and yeah, so that's when we use them. We also use these barbiturate for electroconvulsive therapy, mainly methotrexate, because the methyl group in the methotrexate give him the convulsive effect, so it's gonna generate convulsion during electroconvulsive therapy. And this convulsion is going to be violent because of the psychomotor activity that they generate. The patient is going to be agitated. So most of the time we give it along with a neuromuscular blocker to relax those muscles, and mainly succinylcholine, because they have about the same elimination time. So is parallel. So when methotrexate is going down the body, succinylcholine also is going down. So they are eliminated basically the same proportion. We also use them to treat seizure, like phenobarbital is used. We also use them to treat hyperbilirubinemia of the newborn. We use phenobarbital because it's a potent CYP450 inducer. And we use them also to treat ICP because they induce coma, they decrease the oxygen requirement in the brain, they have this vasodilator property, so they are also used to treat ICP. Now, what is their drawback? Why don't we use them that often in anesthesia anymore since propofol came? Because they just this linger effect, the fact that they get stuck in your fat and they give this sedation forever to your patient. So this is one of the main drawback, and the hangover effect, that's how they call it. And secondly is it has a high risk for abuse. And yeah, so physical dependence, abuse is also something. It has a high rapid tolerance, so even with few doses your patient can be tolerant, so you have to keep going up on the dose to have the therapeutic effect. And the more you get up on the dose, the more it gets stuck in the fat, the more hangover effect, sedation or post-sedation, and then you have this cycle that never finish. They don't have specificity for the CNS. Like we said, only 10% get into the CNS, which is the main target that we want, but majority of the medicine go into other tissue that we don't necessarily want the medicine to go there. And even though I say most of it go into the skeletal muscle, clinically speaking, they don't have any muscle relaxant properties, so it's not helpful. It's like you only give the medicine to have 10% going into the CNS, and then you have to deal with other tissue accumulation. So that's also one of their drawback. They have a low therapeutic index because of their protein binding and medicine interaction. So we don't need that. And they are less sedative in the presence of pain. So if you only give them and your patient is going through surgery and is having pain, their sedative property is not going to be that great. They are potent cardiovascular depressor, so they're going to depress your cardiovascular system. And in matter of fact, the thiopentol is contraindicated if your patient has hypertension. Remember, thiopentol is more liposoluble than methotrexate is more is have a longer duration of action, so it's going to give you that hypotension more than methotrexate. Thiopental is also contraindicated in the patient who has acute intermittent porphyria. Is a metabolic disorder of the heme, but that disorder also promote the skeletal muscle weakness, especially on the upper part of the body. And if you think about your diaphragm and your ventilatory effect combined with the thyropental, so that's why it's contraindicated. So they also dose dependent ventilatory depressant. So if you give them, and let's say your patient develop tolerance, you keep having to go higher on the dose, you're going to also have to fight your ventilation because they're going to depress those ventilation. A matter of fact, we don't give them, we can place an LMA, laryngeal mask airway device with this short acting, because they're going to depress your ventilatory system and your patient will not be able to protect his airway, neither the LMA. So you don't want to give them with the LMA in place. So they also have a high potential to be transferred through the placenta at therapeutic doses for pregnant women. And also if you inject them intraarterially in the arteries, it can give you gangrene and also irreversible nerve damage. And also they promote histamine release, so it's gonna give you a lot of allergic reaction, anaphylactoid reaction. So you want your AP on the side of the bed. And thiopental is gonna impair your neutrophil function. Your polynuclear neutrophil, your first defender, is gonna also thiopental is gonna impair those. And they are also good at giving you venous thrombosis. So these are the main drawback of this barbiturate, and I'm gonna make another video on propofol or other agent that we use for induction, and we're gonna see how better they are compared to this barbiturate that we don't use anymore. Some of the medicine interaction that I could think about is we saw that barbiturates are acid drugs, so their preparation, we prepare them in alkaline solution so they don't precipitate, right? Because we saw that acid drug works better in acidic environment. So if you prepare them in acidic solution, they're gonna precipitate. So these barbiturates are mainly prepared in alkaline solution. So other drugs that are basic drug like opioid, like catecholamine, neuromuscular blocker, they are basic drug base, and we prepare them in acidic solution. So you don't want to mix those solutions together. You can give one and then wait 1 minute before you give the other one to avoid this crystallization and precipitation. So guys, this is what I got for phenobarbital. If you have anything to add, this is what I got for barbiturate. I'm sorry. If you have anything to add, please drop a comment below. If you like this video and would like to see my other videos, please subscribe and don't forget to press the notification bell button. Thank you, and I will see you on my next videos.